Welcome back to the deep dive. Today we are taking a crucial shortcut into some really complex, high-stakes anatomy.
We are.
We're talking about the suprarenal glands, the adrenals, and we're going to decode their dual nature, their incredibly dense vascular supply, and the spatial relationships that define surgical risk.
Right.
Our mission is to give you a foundational, visualization-friendly understanding, moving past just memorizing facts to really understanding the why behind their design.
And that why is so interesting because it's rooted in the fact that these things are basically two organs in one.
Two in one.
Exactly. Embodying this unique biological duality. They're strategically positioned, sitting immediately superior and just a bit anterior to the superior pole of each kidney, all held securely inside the renal fascia.
Okay.
But the thing that truly defines them, and we'll see this throughout our dive, is their origin story. The outer cortex comes from the mesoderm, and it's responsible for life-sustaining steroids.
Long-term stuff.
Right. And then the inner medulla, that arises from neural crest cells. So it's basically a specialized nervous system outpost for acute survival.
That dual origin really does dictate everything, doesn't it?
It does.
So here's how we're going to navigate this. We'll start macroscopic looking at the dramatically different shapes of the left and right glands and their immediate neighborhood. Then we'll follow the blood, which is a story of extreme demand and, well, extreme vulnerability. And finally, we'll connect the cellular layers directly to the clinical scenarios they produce.
Sounds like a plan.
Okay, let's start with what you see, the gross anatomy. What's so striking is that the left and right glands, they look nothing alike.
Not at all. And that really speaks volumes about the different organs they're cozying up to, as you put it.
Right. So when you visualize the right suprarenal gland, what should you be thinking?
Think of a pyramid. The right gland is pyramidal, a compact shape. In cross-section, people often say it looks like a three-pointed star with two lower limbs.
Okay. A pyramid and the left.
The left is completely different. It's usually described as semi-lunar, so more like a crescent. It's flatter from front to back and often just a little bit larger than its pyramidal counterpart.
And these shapes are a direct result of their neighborhood.
A direct result, yeah.
So let's talk about that neighborhood, which is so crucial for any kind of surgical access. What's the right gland up to?
Well, the right gland has an incredibly close and I'd say high-risk relationship with the body's largest vein.
The IVC.
The inferior vena cava. It lies posterior to the IVC, separated by just this thin fascia, and it's also tucked posterior to the right lobe of the liver, specifically the bare area. This gland essentially has this narrow medial face that's in direct contact with the IVC.
So it's sandwiched.
Completely. Posteriorly, it's sitting right on the right crus of the diaphragm, and then inferiorly, it rests on the superior pole of the kidney.
Tucked between the liver, the diaphragm, and the IVC. That sounds like a heavily protected but highly constrained space.
Exactly. Now compare that to the left gland. While it also rests against the left crus of the diaphragm and the kidney, its front face interacts more with the digestive system. Its upper part is covered by the peritoneum of the omental bursa, which separates it from the back wall of the stomach.
Oh, yeah.
And its lower part is uncovered and directly contacts the pancreas and the splenic artery. These differences fundamentally inform how a surgeon approaches the gland.
Right, whether they go retroperitoneally or transabdominally.
Precisely.
Now, here's where the developmental timeline throws a surprising curveball. In an adult, these glands are small, maybe 5 glands each.
Tiny.
But at birth, they are proportionally huge. The sources say they're up to 1/3 the size of the kidney. That rapid size change is just stunning.
It is, and it's all because of a temporary structure. The inner fetal zone of the cortex.
The fetal zone?
Yeah, this zone is a really fascinating example of fetal necessity. It's responsible for this massive output of dehydroepiandrosterone, or DHEA.
DHEA. And why so much of it?
Because the placenta uses DHEA as the essential building block to produce the high levels of estrogen that are required during pregnancy.
Whoa. So the baby's adrenal glands are acting as a secondary hormone factory, supporting the entire pregnancy.
That's a great way to put it. It's a temporary specialization. After birth, that necessity just vanishes, and the gland undergoes this dramatic, planned atrophy.
So it shrinks.
It shrinks fast. The fetal zone just withers away, and by the second month of life, the gland's weight has dropped by over 50%.
Wow.
It takes until puberty for the gland to grow back and regain its original birth weight.
And before we leave development, I read that sometimes pieces of this tissue are found in places they really shouldn't be.
Yes, that's right. The existence of adrenal rests or accessory cortical nodules, it's a well-known thing.
Okay.
Because the cortex and the gonads develop so close to each other in the embryo, sometimes these rests migrate along the genital pathways. You can find them in the spermatic cord, the testis, the ovary, even the broad ligament.
And are they dangerous?
Not usually. They're almost always benign and asymptomatic, but they can definitely pose a diagnostic puzzle if you find one incidentally on imaging.
That makes sense. Okay, let's transition to the lifeblood of these structures. The literature really emphasizes that the suprarenal gland has one of the highest arterial flow rates per gram of tissue in the body.
It's massive, up to 5 milliliters per gram per minute.
That kind of flow suggests an organ that requires constant redundant supply. You can't risk it shutting down.
You absolutely cannot. You can't shut down the body's primary long-term stress manager. And this incredible flow is guaranteed by a triple arterial supply system.
Meaning it gets vessels from 3 different places.
Exactly. 3 distinct anatomical neighborhoods, which gives it this incredible safety net.
So let's break down those 3 sources.
Okay, first you have the superior suprarenal arteries. These usually branch off the inferior phrenic artery. That's the vessel supplying the diaphragm.
Right.
Second, the middle suprarenal artery. This is often a single direct vessel that comes right off the side of the abdominal aorta.
A direct line.
A direct line. And third, the inferior suprarenal arteries. These often contribute the most blood overall, and they typically come from the renal artery. This whole basket of vessels ensures that even if one major feeder is compromised, the gland can still function.
So we have all this blood rushing in, but the way it's handled internally is a masterpiece of functional design. Can you tell us about that microcirculation path, especially that structural shortcut I read about?
Of course. So, once the blood hits the gland, vessels spread out over the capsule, forming what we call a subcapsular plexus.
Okay.
From there, you get these fenestrated sinusoids, think of them as very leaky capillaries, that enter the cortex and run down through the 3 cellular zones. This is where the blood picks up all the steroids.
That it all collects.
Right. The venous vessels from this cortical plexus then drain into a deep plexus near the medulla, and eventually they all collect in the central vein.
But the key is the bypass, right?
Yes. This is a design feature for survival. Certain relatively large arterial vessels deliberately bypass the cortex altogether.
They just tunnel through.
They tunnel directly through the steroid factory to supply the medulla first. The implication is crystal clear. Getting oxygenated blood to the adrenaline-producing cells is prioritized over the slower process of steroid metabolism.
It's a structural guarantee of a rapid fight-or-flight response.
Absolutely. It's stunning.
That dual circulation, a system where most blood serves the cortex, but a direct line serves the medulla, is amazing. But once all that high-flow blood has done its job, it has to drain out. And this is where the system runs into its...
It's Achilles' heel. Yeah, especially on the right side.
Why the right side?
That's the critical anatomical constraint. The drainage is singular via one central vein, and the right suprarenal vein is famously dangerously short. It passes almost horizontally and dumps directly into the posterior wall of the IVC.
And why does that shortness matter so much in a clinical setting? Or, say, in trauma?
It matters because there is almost no give. There's no length, no tethering. During a surgical adrenalectomy or in severe abdominal trauma, that short, direct insertion point means the vein is highly vulnerable to avulsion.
It can be ripped right out.
Ripped right out of the IVC wall. And given the gland's massive blood flow, that means instant catastrophic hemorrhage.
Wow.
The left suprarenal vein, on the other hand, offers a bit more safety, it's longer, and it drains inferomedially, usually into the left renal vein.
So to summarize,
Yeah.
if you damage one of the 3 incoming arteries, the gland is probably okay because of the redundancy.
You're probably fine.
But if you damage that single outgoing vein,
You risk infarction of the entire gland. The venous drainage is the bottleneck. The source material is very clear. An injury to the single suprarenal vein is far more likely to cause gland necrosis than an injury to one of the multiple incoming arteries.
and just to complicate things.
Just to complicate things, we know that venous variants are present in a significant percentage of patients, up to 13% in some surgical series.
We've covered the supply lines. Now let's talk about the control lines. Innervation. Given the sheer speed of the response this organ is known for, I'm guessing it must be one of the most densely innervated structures in the body.
You are 100% correct. Relative to its size, the suprarenal gland has the greatest autonomic nerve supply of any organ. period.
The greatest of any organ. Whoa.
And nerves form the suprarenal plexus, which is medial to the gland, and it draws input from the coeliac and aortocoronal ganglia.
And the signal for that instant adrenaline dump, where does that come from?
It is the sympathetic nervous system, but with a really unique twist.
Oh.
The main stimulus comes from cholinergic preganglionic sympathetic fibers, traveling mostly via the greater thoracic splanchnic nerves. But crucially, these fibers skip the usual peripheral ganglion. They synapse directly onto the medullary chromaffin cells.
So it's a direct line from the spinal cord to the adrenaline-releasing cells.
A direct hotline.
No relay required.
Exactly. It bypasses the postganglionic step, which maximizes the response speed. These nerves primarily regulate blood flow and stimulate that catecholamine release, but their influence might extend even further, maybe subtly modulating corticosteroid hormone production as well.
Now, for the microscopic architecture, the factory floor, this is where we link structure directly to function. We've got the 3 zones of the cortex and then the medulla. And as a reminder, the cortex is essential for life, the medulla is not.
Right. So let's visualize the cortex, moving from the capsule inwards. The outermost layer is the zona glomerulosa, or ZG.
ZG.
Its cells are arranged in these rounded clusters, like little balls, and they produce mineralocorticoids. The main one here is aldosterone, the hormone that manages water and electrolyte balance.
Okay, so ZG is salt and water. What about the middle layer, the thickest one?
That's the zona fasciculata, or ZF. It's broad, and its cells are arranged in these beautiful, straight columns, usually just 2 cells wide, separated by those leaky sinusoids we talked about.
Hey, its job.
This zone produces glucocorticoids, primarily cortisol. Cortisol is vital for maintaining blood sugar, regulating metabolism, and mediating long-term stress responses.
And the deepest layer of the cortex.
That's the zona reticularis, or ZR. Here, the cells are in branching, interconnected cords. This layer is the primary source of the adrenal sex hormones precursors for androgens, estrogens, and progesterone.
Okay, so that's the cortex. Now crossing into the medulla, the neural crest-derived core.
The medulla is where those preganglionic fibers finally terminate. It's composed of specialized cells called chromaffin cells, which again are functionally just modified sympathetic neurons.
And these cells release.
They store and release the catecholamines. Noradrenaline and adrenaline. This is your instantaneous response to fear, anger, or extreme stress.
And what's bundled with those catecholamines that often surprises people?
They're packaged together with chromogranin proteins. But what's often missed is that these proteins also include encephalins.
Encephalins.
They are powerful, opiate-like analgesic proteins. So when the body initiates a massive stress response, it is simultaneously activating an endogenous pain relief mechanism. It's helping the organism survive an acute injury or threat.
That is amazing. Understanding these zones, then, isn't just academic. It's the absolute foundation of understanding the pathology.
It is the critical clinical connection. If any zone starts pumping out hormones on its own because of a tumor, the syndrome that results is defined by that exact cell type.
So let's walk through that. If the ZG, the mineralocorticoid zone, develops an adenoma, what syndrome emerges?
That leads to Conn's syndrome, which is defined by excess aldosterone.
And what does that look like clinically?
The typical picture is hypertension, hypokalemia, so dangerously low potassium, and a subsequent metabolic alkalosis. If it's a solitary adenoma, surgery is the treatment.
Okay, and moving deeper to the ZF, the cortisol producer.
Excess cortisol leads to Cushing's syndrome. This one is classically associated with central obesity, the characteristic round moon face, a fat pad forming the buffalo hump, purple striae on the abdomen, and hypertension.
And that's diagnosed with the dexamethasone suppression test.
Right, to confirm that the normal feedback loop has been broken.
Finally, the medulla.
Yeah.
The source of the most acute crisis pathology.
These are the pheochromocytomas.
Phayos.
Catecholamine-producing tumors that can cause terrifying episodic symptoms, severe, rapid-onset hypertension, tachycardia, pounding headaches, and just profuse sweating.
I've heard they show up on MRI as a light bulb.
They do, the famous light bulb sign, because they are markedly hyperintense on T2 sequences.
And surgically, these are not straightforward. The acute danger is so high.
Absolutely not. The release of catecholamines when you're manipulating the tumor can cause a life-threatening intraoperative hypertensive crisis.
So what do?
You have to prepare. Mandatory preoperative preparation involves alpha-adrenergic blockade, often using drugs like phenoxybenzamine, to stabilize the patient's blood pressure before the operation even starts. You have to diffuse the biochemical bomb first.
That makes perfect sense. To round out the pathology, what about the most aggressive cancers and the incidental masses people find?
Well, the primary malignancy is the adrenocortical carcinoma, or ACC. It's rare, but it's exceptionally aggressive. It often presents late and large, averaging about 10 centimeters.
And the prognosis.
It's poor. Treatment is radical. En-bloc surgical resection of the tumor and anything it's touching. On the flip side, the suprarenals are also a very common site for metastases from cancers elsewhere, particularly lung, breast, and kidney.
And the benign findings, the incidentalomas.
Right, we frequently stumble upon non-functional masses. Myelolipomas are a common one. Benign tumors made of fat and hematopoietic cells. They're inert and easy to spot on CT because the fat shows up with negative Hounsfield units.
So you just watch those.
Typically, if they're small and not causing problems, you just monitor them. So if we pull it all together, we've synthesized this really complex structure. The cortex is managing the long-term life essential functions through steroids.
And the medulla is handling the acute stress with this rapid-fire catecholamine release. This functional dualism is built right into their anatomy.
Perfectly said.
And for you, the learner, the key takeaway here really is visualization. You have to internalize those distinctions. The pyramidal right gland hugging the vulnerable IBC versus the semi-lunar left gland that's relating to the pancreas and stomach. These differences don't just exist on a diagram. They dictate the entire surgical approach and, really, the risk profile.
And that leads us to our final provocative thought for you. Given the short, fixed nature of that right suprarenal vein inserting directly into the IVC, and considering the incredibly high blood flow the gland demands, how might advancements in vascular imaging or interventional radiology offer new ways to manage or stabilize that singular high-risk point of venous drainage, potentially redefining the safety of right-sided adrenal procedures in the future?
Yeah, that's a fascinating question, tying future innovation directly to this foundational anatomy. Thank you for joining us for this deep dive into the suprarenal glands.
My pleasure.
We hope this has clarified the complexity and given you the essential knowledge you need. Keep learning, and we'll talk to you next time.